Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my intention, my goal to help you with your prostate health and how to live better with age. Today we have Dr. Minhaj Siddiqui. I'm hoping I'm not butchering your name, Minha. Here, I try.
Minhaj.
Minhaj. Thank you.
Yep. Thank you.
I wouldn't be the first to say Minha.
No.
Thank goodness.
I've heard it all. That was pretty. It's recognizable. I'm happy.
So Minhaj, we met at the AUA recently, and it was like, I don't know. I hate to. It was like love at first sight a little bit. Why? Because like I've read some of your work, or much of your work. I've seen you in panels. I was like, yeah, this guy gets it. And anybody, of course, I'm biased. Anybody who thinks diet, even remotely, and prostate cancer, I'm like, oh, perfect. This is my guy. I can't wait. So I met you. I was like, oh, that's great. And we met at a lunch, and it was great. And then you said, yeah, we connected right away. And here you are. You're on the pod. So thank you so much for being on. I know you have a busy clinical life, research, and family. So thank you for being on.
Oh, it's my pleasure. I mean, similarly, Dr. Gio, like you're doing just such amazing work, and it's been a, I was already familiar. I've seen you talk, and I think like the things you touch base on are sorely needed in our field, and you being such an advocate, like an implementer of putting together research and like making it understandable for the broad audience, both clinicians and patients, like that is a huge area. And we met at a lunch with Howard Walensky.
That's right.
Who I think bridges, is also a communicator of sorts. I mean, he's a journalist, and I think I've collaborated with him, and you've worked with him in different ways, I'm assuming, and so
yeah,
it was fortuitous that brought us together. And
I'm grateful for that. I am. I had no idea. Howard didn't mention who was going to be there, and I thought it was just going to be him and I, and then here you were there. I'm like, this is great. This is great. So when I looked at your bio, University of Maryland, it starts with your medical school education, which started at Harvard. Then I dug a little deeper, and it turns out you have a bachelor's degree in bioengineering, I think, from MIT. Now, these are top schools. That cannot be ignored. I know you guys are super humble. Everybody from like top schools don't even want to say it these days. But that's impressive. And here's why I think that's impressive. I know a few MIT guys. I don't know that many, but maybe a handful or so. And I joke with them with the fact that, that they're all on the spectrum in one way or another. Right? And we always discuss about emotional intelligence. Do you even know what that is? Now, the reason why I thought that was interesting with you is because I would have never guessed that, nothing to do with your intelligence, but to do with the fact that I would never have guessed that you graduated from MIT, because I have the stereotype in my head that everyone who graduates from MIT is on the spectrum in one way or another, having zero emotional intelligence. How do you do that? Or did I get it wrong? Like, I know you have 3 kids. We were talking about you're involved. Father's Day is coming. Clearly to me, you are involved and you have EQ rather than just IQ. Am I getting that right? And how do you do that?
That's really funny. Yeah. No, I mean, I think, I'm truly grateful for the education I've like been able to undergo. And I think that going to MIT and then, Harvard, and the Harvard program I actually was involved with is this one called Health Science and Technology, HST, which is a joint MIT and Harvard venture for people interested in academia. I mean, I have always been good at math and science. Just came natural to me. I would take a advanced engineering differential equations course 10 times over before I would do a literature course. And
Right.
it's just like everyone has different skills and different things that click with their brains.
Yeah.
And to me, the STEM kind of topics were always good. And then when I was in there, I was a so biomedical engineering. 1997
Mm-hmm.
was when I was in undergrad. Biomedical engineering was still not considered a pure engineering, so it
Mm,
was not allowed to have its own major.
mm,
They were like that. This was the fight that they were fighting.
mm,
It was only a minor, and so I was a chemical engineer. But with biomedical engineering, there was a couple of exposures I got during my time doing that type of work. I got involved with this lab called Langer
mm-hmm.
Lab. Bob Langer, who's an amazing individual. He's a tissue engineering and stem cell kind of guru.
Oh.
He's had like 20 companies spin out from his lab. It's one of the largest labs at MIT, and he
Mm,
was growing organs in the lab. And that's what kind of bridged the medicine connectedness and gap with the engineering, and put me on this road that of like academic medicine, where I'm interested in kind of helping people.
mm-hmm.
And you learn these skills as you kind of traverse your career.
Did you have to
And
learn how to connect with people? For some people, that's natural. For example, I love that's always been a natural thing for me, right? So, just connecting with people, figuring that process out. I've been very curious about that. Did you have to learn that? Did you have a difficult time connecting with people because you're so into your, what statistics and your work and math and science?
yeah, it's funny. I think yes and no in different contexts. I am uh you know I'm an intro. You do the what's it, Miggs, Briar Miggs, or whatever it's
Yeah,
called,
that's
like the
one of them.
INT, right? I'm like the INTJ or something
Yeah,
like that. I'm like I'm an introvert.
yeah, yeah.
And so, and I think those things, like I mean, I remember doing those types of analyses on
Uh
myself,
huh.
and like they're interesting because like they don't say that this is the life you have to live. You can't communicate with people, but they tell you like what comes naturally to you and
Mm-hmm.
what doesn't come
Mm-hmm.
naturally to you. And then that helps you kind of focus on like what you should be more objective about. Like I'm married to an extrovert. It's
Oh,
very
that's.
clear. It's very clear that I'm the introvert and she's the extrovert.
I think she's
And
helped. Maybe she's helped you
yeah,
come out a
no,
little
I
bit.
think like I did learn actually in undergrad that there is this kind of, you don't generalize anything, but like there is a general difference between like MIT type personalities and like other, like
Hundred
I actually
percent.
ran this
Yeah.
conference during undergrad that was a joint Harvard and MIT
Mm.
conference. And I felt that the MIT crowd team, if you will, of students was coming with all these great ideas and like just like really deep geeky knowledge on the topic
Yeah.
matters. Okay. More so than I felt like on the Harvard side. And since I went to both, I feel like I can badmouth them and it's okay. But but I felt like when we had joint
Yeah.
meetings, who knew how to like kind of just communicate better was the Harvard
Yeah.
side. And it was like such an
Yeah. Yeah.
interesting kind of match. And I think early on I saw that like
Ah,
like you have to be both knowledgeable on topic matter but also a communicator. And I think like I have tried to
fantastic.
incorporate that.
Fantastic.
uh
And it's unbelievable that you got that early on, that you were able to pay attention to that, right? Because I see adults that are from these schools and are like, they still haven't, right? They're still very comfortable in the way of being, and that they're unwilling to step out of their comfort zone and be
yeah,
more of an
certainly if
extrovert.
you want to survive in medicine, I
You
mean,
have to.
you need both. It is a person, patient facing
Yeah,
world. Even if you're a surgeon, you
absolutely.
still, and so yeah,
Oh, that's
it is
fantastic to
absolutely
know.
fundamental.
I was really curious, man. I look MIT was like he doesn't come across that way, and as I'm gonna have to ask him. So, and then I think your wife has a lot to do with it. By the way, that's just my opinion.
I'm sure she does. She would say so too, and I would say so too. To be honest,
So,
yeah.
all right. So let's dive in into several elements of prostate cancer. So, We have an episode on active surveillance with Dr. Aditya Bragodia. Always trying to get the names right.
Mm.
Who I know you know. So we had a general overview of that, like who's the right candidate and so forth. We didn't dive in to this sector of intermediate risk men with prostate cancer, right? And of course, lo and behold, you have a paper on it written in 2019, I believe, or 2022, actually, not that long ago. And you have a review paper on active surveillance in favorable intermediate risk prostate cancer, questions and controversies. Let's define what intermediate risk means, first of all. So we know it's not Gleason 6, that's low risk.
Hmm.
What is intermediate risk? And what is your methodology of determining, yep, this is a what we would call low favorable or high favorable intermediate risk, or you could use the right terminology if I'm butchering it as well. So
Absolutely,
let's get
yeah.
right into that. What is intermediate risk
That's
prostate
great.
cancer?
Yeah. So, I mean, I think the classic definitions are, so, whenever you're diagnosed with cancer, the first thing you get is a grade and a stage. The grade kind of gives you an insight into like how the cancer cells look
Mm-hmm.
and what they're capable of
Mm-hmm.
doing. The stage tells you what they are actually doing. And so the grade, we have this traditional scoring system, the Gleason score system, and the Gleason score system starts at 6, as we discussed, and goes up to 10. And it gets a little like kind of detailed. And so 7 is intermediate risk. Now, within intermediate risk, there is a favorable intermediate risk and an unfavorable
Mm-hmm.
intermediate risk. And so it turns out that the 7s have 2 layers to them.
Mm-hmm.
And they're broken up into components. And so there's a 3+4 component and a 4+3
Mm-hmm.
component. And as you could guess, the 3+4 is the favorable intermediate, and the 4+3, the higher number being first, is the unfavorable.
Mm-hmm.
There is a newer system out there. It's called the grade group
Yeah.
system. I actually, when I tell patients about these diagnoses, I tell them about the Gleason score because it's historically everywhere. And if you Google it, you're probably going to see a Gleason score.
That's right.
But the grade group system is a lot easier to understand. It starts at 1 and goes to 5. So none of this starting at 6 business, which I think throws everyone
That's right.
off because, 6 is a low risk cancer, but 6 out of 10 sounds kind of concerning. And so I think the mindset is better when you start at 1, go to 5, right? 1 is low risk, 2 is favorable intermediate risk, 3 is unfavorable intermediate risk.
That's right.
And so depending on which system you use, it's either a 7 or it's a 2 or a 3 on the grade group system. Both are saying the same thing.
And within that system, grade group system, they are using the Gleason score, but it just makes the numbers just easier, an easier conversation with patients.
100%.
GG1,
Yeah.
GG2, GG3, etc. Is the Gleason score the end all be all? Or is that the first thing? Like, so
Yeah.
I've heard that in numerous conferences from, some of our senior members of our profession. And it's like, yep, Gleason score is the ultimate, and what's your opinion on that?
Yeah, I think there's always nuance, but I think that the grade of the cancer does drive the majority of the decision making. Having said that, you take into account PSA, and certainly I think PSAs of less than 10 are considered low risk. 10 to 20 is intermediate risk. 20 and higher is high risk. Okay, you could take into consideration MRI findings. The MRI findings in particular give you stage. So we mentioned grade is how a cancer looks under a microscope. It looks like what it's capable of doing. It doesn't necessarily tell you what it is actually doing, whereas the stage is what it's actually doing. And so is the prostate cancer contained within the walls, the capsule of the prostate? Has it broken through into, through the capsule itself or into like the surrounding structures, such as the seminal vesicle? Does it look like it might be in the lymph nodes? Certainly if it's like, in the bone or something, that's a whole different beast as well. And so these, grade and stage are both important. You want something that's organ confined to keep it as intermediate risk. Once it starts breaking out of the prostate, even if the grade group or the Gleason score is a grade group 2 or 3, then if it's breaking through the prostate, it becomes high risk. Or if the PSA is super high, it becomes high risk. And so these are the things that you kind of have to finagle a little bit. There's never kind of a black and white answer. You're always kind of integrating information to risk stratify patients.
Yeah, so even if it's a Gleason 7 3+4, but there's evidence that it's outside the prostate, then that's not low favorable anymore. Yeah.
Exactly. Yeah.
But it turns out that most perhaps Gleason Sevens 3+4 are still within the capsule. If it's a true Gleason 7 3+4, which leads me to my
Exactly.
next question: how do we know that? So if
Yeah.
we're taking 100 cores of a prostate, no one does that, so I don't want the listener to freak out. But I'm just giving an example. If you take 100 cores of a prostate, depending on the size of the prostate, you're probably taking 1-2% of the whole prostate. I mean, there's some big prostates out there. So how do we know that we have it all? What's the best methodology of saying, yep, this is a true Gleason 7 3+4?
Yeah. I mean, you're hitting on fundamental questions in our field. And so the only way you know for sure, with no loss of
Remove
certainty,
the prostate.
is by removing the entire
That's
prostate, right? And anything short of that, you're
so
sampling.
we can remove the prostate, test it, and put it back.
Yeah,
in.
and put
We
it
can't
back
do
in,
that, right? I
obviously,
just
right?
want to make sure.
And so historically, this was a big problem, and it's still a problem, but fortunately not as bad as it was. And so before, you would do typically 12 evenly spaced kind of grid-like samples, kind of like a battleship, a 3x4
That's a
grid.
great analogy. I've never thought. I have
Yeah,
an image in
yeah,
my head. That's great. Yeah, like a battleship,
yeah.
right?
So you do, exactly. So you get the 3x4 sampling, and you hit what you hit, and you miss what you miss, and you hope that you hit the areas that are reflective of the entire prostate. It turns out when you did it that way, that somewhere between 30, a third, to 50%, a half of the time, when you did the prostatectomy, you would find actually more aggressive cancer in the prostate. Mm-hmm. And so the random sampling or the template sampling method is inherently somewhat inaccurate. Okay, and so this has kind of then led to the era of MRI integration, and which is now kind of 10 years in, and is pretty pervasive. So it's not that new anymore. And the MRI, what it does is it gives you a map, right? It, like, if we're using the battleship analogy, it lets you see where all the ships are, and it lets you put your shots, where they matter. And so now we can do the target biopsies, and there's like technical limitations and stuff, and so it's not 100%, but the rate of upgrading after prostatectomy from biopsy went from about 50% to maybe 10%.
That's amazing.
So we can feel a lot more confident now that what you're sampling is actually probably what you have. And then there's still caveats to all of that, but that is in general where things have come.
Yeah, that's a huge improvement, right? So you can, and it's an MRI targeted, also known fusion biopsy, where they blend in the MRI with the ultrasound, and I guess the images pop up, the areas of interest just kind of pop up, and you can target right that area. You still take a couple other samples just in case. Is that what you do still? So you go,
100%, because MRI does not capture 100% of cancer. There are variants of prostate cancer that don't show up well in MRI, so you have to do the random sampling to make sure you're not missing it.
So there is a 10%. So there's only a 10% chance of there being an upgrade of their type of disease after a prostatectomy, as opposed to 50%. Yeah. How can we lower that a little bit more? So some of the genetic biomarkers, is that helpful?
Yeah, so the use of biomarkers is rapidly growing. It's a little tricky. I think that the use of biomarkers is still not well proven, but I think that it has a lot of promise. And I think that there are people doing really excellent work. I think University of Michigan in particular, with this music initiative that they have this trial called G Major, which is looking at active surveillance. It's actually completely mundane to this topic today, in an intermediate risk population, using biomarkers versus not using genomic biomarkers.
That's going to be helpful.
So so I mean, all of this has really come together into the topic we're talking about the intermediate risk prostate cancer for active surveillance, because I think prior to the availability of all these extra tools, it was pretty much not standard care to do active surveillance for intermediate prostate cancer.
Yeah, I mean, you had a
You know,
50% chance of getting it wrong. That's not insignificant.
yeah,
So you put somebody
yeah,
on active surveillance, which the active surveillance movement began before MRI targeted biopsies. There's literature up to 20 years, I want to say. Yeah.
you got it. Yeah,
So,
absolutely.
yeah, I think everyone is doing a much better job in really determining who's the right candidate. Um, all right, so these biomarkers so this includes Oncotype DX, Decipher, Polaris. I don't know if
Hmm.
there's any others. Do you know?
Those are the three
Yeah.
main ones. Yeah, and you know what they're looking at is they're looking at they're you know this is how I describe it to patients that you know every cell in your body has DNA, right? It's the instruction
Mm-hmm.
book to how that cell needs to
Mm-hmm.
work, right? The cell has any given time 100 jobs it needs to do. It goes to this instruction book to figure out like, okay, how do I do
That's
this
right.
job? Okay, and then with cancer, a page gets torn out, some kind of mutation happens. Now, just like with the instruction book, you can tear out a page that doesn't really matter. It might be in the French section of the book, and so you're not
Mm,
even using that part of the book, right? It could be in the title page, or it might be like a really critical page,
yeah.
and you're struggling to know what to do with it. And so the genomic analysis can help predict future behavior,
Mm-hmm.
and it's not perfect, but that's kind of the idea. And so you get these situations where you can have the same risk cancer, two patients with the same risk cancer, I say a favorable intermediate risk prostate cancer, same DNA, same PSA, same everything,
Mm-hmm.
okay, uh, but one might be a low risk and one might be a high risk based on genomic
And what
classifiers,
would you do in that?
and
So
and
the guy with the high risk, would you still put him on active surveillance? What would you do?
I I I use them to counsel patients. I think that any intermediate risk prostate cancer patient that is considering active surveillance, I make sure that they understand that this is not the same thing as a low risk prostate cancer who wishes to go on active surveillance. A low risk prostate cancer, I would say things have come far enough along, except for the few and far between exceptions, that the standard of care recommendation first line should be
Mm-hmm.
active surveillance, not surgery, not radiation, not hormone therapy. It really, like, you should have a really good excuse to not do active surveillance
So
for low
Scott
risk
Egner
prostate
would say
cancer.
let's not call it prostate cancer. So what's your
Yeah,
opinion on that?
exactly. I don't
Yeah.
disagree. I think there's
Yeah.
nuance to that because you do need to
Yeah.
follow it. And so while not calling it prostate cancer, we still need to capture. There's so many
Mm.
layers to that because there's a lot of implications to calling it prostate cancer on patients. But if you don't call it prostate cancer, you still need to make sure that the insurance coverage would still be there for their future care and follow up, because it does have involved care and follow up. But at the end of the day, I actually think a lot of good could come from stop calling it prostate cancer, because cancer is such a loaded word, and it remains a loaded
So
word. But intermediate risk prostate
yeah,
cancer is
sure.
different.
So as a quick aside, I'm torn with whether or not we should call it prostate cancer for no other reason that it's a great motivator for men to do the
Yeah,
aggressive lifestyle interventions that I recommend. So here we have,
yeah.
low risk prostate cancer, and it will likely not kill you, but the C word is there, and they're gonna do everything I'm asked. So now they reduce their overall risk of premature mortality from many other things, not only for prostate cancer. So from that element, from that perspective, of course, I'm not thinking policy or insurance. I'm just thinking practicality and how men function typically, which is in general, you may find this interesting. Men don't really care much about health. They care about
Yeah,
performance. But when
yeah.
their life is threatened or they perceive that that is the case, they're willing to do anything and everything.
They will flip on a dime. I
Right.
couldn't agree more. I think there's a couple of points worth making here. I think I agree. I think that's my experience with
Yeah.
many patients. I think that people will, they'll ask me. I know they get a new diagnosis of prostate cancer, low risk prostate cancer for the moment, and I'll tell them active surveillance. They buy onto it. They say, "What can I do to improve
Mm-hmm.
my outcomes?" I'll say, "You can lose some weight." I mean, it's not a 1-to-1 thing, but in general, it's, I mean,
Yeah.
if they're obese, and I'll say like, look, it can't hurt you anyways, right? It's good for you. It's probably good for you from a heart
100%.
perspective and just your overall health. And
Yeah.
they'll do it. I'll say like, and there is some evidence to say that having excess body fat can actually encourage progression. And so like, so there is that kind of thread that they can hold on to. The whole thing about like naming it prostate cancer, I mean, it's a fascinating thing. I mean, it comes from the fact that like, I think part of this comes back on like us physicians, that like we as a community have not been great about implementing active surveillance. I think we could be better. And I think that even today, 40 to 50% of patients with lower risk prostate cancer in the United States are still treated upfront rather than put on active surveillance. And like, I don't think that number is going to ever be zero, nor should it be zero, but it probably shouldn't be 50%.
Right.
And my understanding is like, and so like, to me, it feels like not calling it cancer is a compensatory mechanism to try to avoid overtreatment, which maybe that's the way it has to be, but I'm not sure if that's the best way. Like I did like a 2-week kind of exchange program last year with London, University College London, and I learned a little bit about how like they practice prostate cancer care. And over there, if you operate on a Gleason 6 prostate cancer, you have to go up in front of a board and justify why that operation was necessary. And it may be necessary, and if it's indicated, it's fine. But you should have a good reason. Is that
the same thing with if they do a focal treatment on that tumor?
No, I think focal gets a little tricky, I think, but I think, but certainly if you do radical prostatectomy, I think that is the thing.
Interesting.
Yeah. And
so here I'm listening to you, right, and you're sort of seriously discouraging people from getting a prostatectomy if that's what you think they should do. And most patients would say, that come to me anyway, they'll say, look, all these surgeons, all they want to do is surgery. All they want to, they have a hammer, everything looks like a nail. And I gotta say, like, not the guys I know, not surgeons I know, like a lot of people are on the same page. Sure, there's some scrupulous guys out there that if you have a 5% Gleason 6, they're gonna want to remove your prostate. But it's interesting how that's not the case with many practitioners in this day and age, and kind of I guess looking at things outside the box, or that's in the box, is that's you're just going with the science.
Yeah, and fortunately, I think USPTF, U.S. Preventive Task Force, did the whole recommendation against PSA years ago, partly because of the harms of PSA screening being overtreatment. I think it really opened up the eyes of urologists. I think it started this movement to kind of clean shop and be more thoughtful about the real risks and benefits of treatment and like the harms of overtreatment. I think there's still a ways to go, but I do think things have come a long way. And you look at like trends of active surveillance over the last 10 years, and it's improved dramatically. It still has a way to go, but it really has come a not and hopefully
even in the US, I know overseas it has a higher trend, but in the US we were a little bit not so much into active surveillance, but definitely more of it now. Going back to the intermediate risk patient. So this is a patient with a Gleason grade 2, which is defined more or less with a Gleason 7 3+4, PSA of 10 or less, roughly. At what point? So let's say it's a Gleason 7 3+4. All 12 cores are that. Is that a candidate? Is that considered favorable? In other words, how many cores need to be positive with a Gleason 7 3+4 for it to be favorable or not favorable?
Yeah, that's perfect. Yeah, so I think the thing is that not all 3+4s are good active surveillance candidates, in my opinion. And this is we're getting a little bit into opinion now, because I think that there's a range of opinions out there. But I think that there's low volume 3+4 and high volume 3+4. And how you figure out volume is the tricky thing. I think this is where the field is at. I do a couple things. And so I look at the MRI and I get a sense of how much space within the prostate is being occupied by cancer on the MRI. And I look at the biopsy core. Within the biopsy core, see the whole 3+4, 4+3. The way that comes about is that there are tumor cells that look like threes, and there are tumor cells that look like fours, and and if you have and they're mixed together, and so if you have more than 50% pattern fours, then you're a 4+3, and if you have less than 50% pattern fours, you have 3+4. Now you might have 45% pattern four, or you might have 5% pattern four. Those are different entities, in my opinion. And so I actually use, and the pathology reports will actually say this. They will typically say the percent pattern four was
That's right.
10% or 30%. And so I use 20%. I think there's some data to say that 20% is actually a pretty reasonable cutoff. And similarly, I used 20%, 1/5 of the prostate, roughly volume-wise, being occupied by cancer as my cutoff. And so I think that is the number that we've kind of come up with. And so, I think that if you have a low volume intermediate risk cancer, those are patients who are likely to do well. If you have a high volume one, all that's going to happen if you have high volume is that you're just going to progress pretty soon. I mean, that's common things being common.
Okay.
That's going to happen.
So definitely not a good scenario for active surveillance in men with high volume intermediate risk, Gleason 7 3+4.
Even if it's favorable. Exactly. Yeah.
So let's go over your cutoff. And I understand that look, I think that when people come to my office, like, you want my opinion. I've seen thousands of patients and I've done lifestyle things for thousands of, my opinion matters. So you want my opinion as much as the research. So I care for your opinion, Minhaj. So in your opinion, what is the right cutoff in general for men with intermediate risk prostate cancer? At what point will you say, all right, this patient is good for active surveillance, but this other patient is not?
Yeah, I think a couple of things that I look at. So the pattern percent four, is 20%, and on the MRI, no sign of extracapsular extension or anything beyond the prostate. I do tend to get genomic classifier tests on these. I use the Decipher, and I like to see them being towards low. Sometimes it can just peak into intermediate. I'm okay with that, but not high. And those are the three main things that I will go over: the MRI findings, the percent pattern four, and the
genomic
genomic testing. Yeah.
PSA 20, 25.
Yeah, I think here's the thing: you have to contextualize PSA with the prostate volume, and so if you have a massive prostate, which happens to have some prostate cancer in it, PSA density is a little better. I can't say that I have like a well thought out cutoff that I use, but I mean, certainly if you're 20, 25, like if you're in the tens, but you have a big prostate, and so your PSA density is less than 0.15 ish.
Gotcha.
That's okay. If you have a small prostate and your PSA is 10, that's more concerning. PSA is 20 and above. Usually, prostate can't really be that big, so that it's probably a concern. And
I think that's pretty clear.
With that.
Is there such thing? I'm about to ask a silly question, but understand, the patients that see me don't want anything. Typically, I don't want anything. It's sometimes to a fault. And then they disappear. I just ask them, don't disappear. Let's keep a close eye on this. Then they disappear, some of them, and then PSA is 1,000 or something when they come back, and then this, spread. But is there such thing as low favorable Gleason 7, 4+3, low favorable Gleason 8? Is there such a thing remotely possible? Or once the Gleason score is at a certain point, that's it, it's higher grade and something needs to happen?
I think, as far as I'm aware, the breakdown that we have with unfavorable, favorable, that's probably it. I think that the nuanced risk stratification within a certain tier comes from the other things. So it comes with PSA and MRI. We
That's
didn't
right.
talk much about
Right.
PSMA yet, but PSMA
So are
is
you
really
using
hitting things
PSMA? Let's go
hard
right
and
in
it's
there, actually.
helpful.
That's what I was thinking as I asked the question.
Yeah.
Um, how, and a lot of it depends on insurance coverage, and that's still a big issue in the US,
Yeah.
right? But I think is a
Yeah.
phenomenal test before anything, right? Before any procedure, before any treatment, so that like, we know that's a great method of stratifying. Let's put insurance. I guess I don't even know if we should, because if the insurance, I mean, not people are going to pay thousands of dollars, though some have. But what is your approach with using a PSMA at this point with the information and data that's available?
I don't use it
Yeah,
for
right,
this side of the spectrum.
right.
I use it for
And
the
that's
other side of the
because of
spectrum.
insurance
And so I use
issues,
it on high
or
risk. No, I don't think it's
right,
proven in
okay,
this side of the spectrum. I think it's a spectacular test for finding cancer
yeah,
that has left the prostate. I have used it in
sure,
recurrences after radiation to localize cancer within the prostate, but like primary characterization of the primary cancer and differentiating something about that tumor based on PSMA is not well proven yet. So I think it's a pure research space. I think like it's not
yeah,
disproven either, but at the moment I don't have a really thoughtful way to integrate it,
gotcha,
so I haven't done it.
yeah,
I mean, the insurance thing is interesting because it turns out PSMA is in particular fascinating. You know, again, actually
mm-hmm.
that whole London thing I did,
They
they
do.
use it like water
I was
there.
just chatting
It
with Mark
is, and it's
Emberton,
because
and he's like, "Yeah, we use it all
yeah,
the time. We use it before." Oh,
yeah, it's like an
exactly,
X-ray there. It's amazing. I was like,
exactly.
really? Like they're getting PSMAs and everything, and you're like, because it's not a massive cost there. There's like for any number of reasons, you know, I'm not totally like I haven't read up on it or anything like that, but like for whatever reason,
Yeah,
it's not expensive there. Um, and so it is fairly ubiquitous. And I suspect like more because of that and because of the widespread use. And then Australia is other place that they have really extensive use of it, actually, probably even
mm,
more than London apparently, or England. And so I would suspect that we will see thoughtful analysis on this topic from those places
mm.
because they're already doing it. And then if there's some clinical trials going on here, that'd be great too. But until now, between the insurance coverage and just not having a reason to know how to interpret those tests,
Interesting.
I don't
I
get
do
those
plan to
tests.
have Mark on. I just saw him and talk about what they do in the UK, just out of curiosity, and maybe to look at trends as to where we might go within time.
Yeah,
You know.
it's great to talk about that topic. I mean, I'm sure you have
Let,
a ton of insights. Yeah, I mean, this
yeah.
gets into like an interesting topic that, like in general, I think you know, you want to know when you're ordering a test. Sometimes, like when patients get these diagnoses, they want the test, and I think like information is good,
Yeah.
but you want to know how to interpret
Yeah.
it before you get it,
Yeah.
not after. You know, and so it's you know whether it's any number of biomarker tests that we do, um, and so like the genomic thing, I'll get it in the intermediate risk cancers because I'm on the fence. I don't get it on low risk
Mm-hmm.
patients because I don't think I'm on the fence with those patients, and I don't want
Yeah.
things to muddy the waters, and I don't want to
Yeah.
cause angst in the
Mm-hmm.
patient unnecessarily. And so I'll tell them, I'll be like, look, even if they bring it up, I'll say I really recommend against it in this situation because you know what are we looking for, and does this
And
test get us
what
there?
if I think you're low risk, and then this test indicates that you're not low risk, you're higher risk? Is it now? Is gonna now you're sort of forcing me
Yeah,
to take action and do some sort
yeah.
of treatment.
Especially in a situation where we have so much data saying that if you're low risk and we've characterized you in the ways that historically been characterized, you're going to do well. And suddenly this test, which is
Mm.
unproven in this space, is giving us conflicting data. Do we go with the unproven thing or do we go
Right.
with the 20 years of data? You know, and so that's why you don't want to like if you have a good answer, you don't want to like mess with the good answer. But if you're in a gray zone, then
Yeah, that's a
certainly
good approach.
get more information.
Let's talk about a little bit about the metabolism of prostate cancer, which again you've written about, and I've referenced you before, referenced your paper before I ever knew you. Um, you could take it away in any direction you want, actually. But let me preface by saying that and certainly my world, and my world is includes integrative oncologists and people who do nutritional oncology and things like that. The ketogenic diet has been very popular for cancer therapies, right? Ketogenic diet implies that you consume a high fat diet, not necessarily a high protein diet, because protein can also be converted into glucose. And certainly a low glucose diet is part of a ketogenic diet. So it's more of a high fat diet in the attempt to use for your body to convert fats into ketones that where your healthy cells can definitely use for energy. But cancer cells seem to have a hard time using ketones for energy. They use glucose and things of the fact. This all stems from the Warburg effect. And that's what a lot of my colleagues have written books on it and so forth. That's for cancer in general. We know that not all cancers are created equal. So what can you tell us about prostate cancer and the metabolism of prostate cancer as it compares to other cancers?
Yeah, it's a fascinating topic. So I mean, this kind of getting back to that initial conversation. I I went into medicine wanting to be an academic, physician scientist, if you will. That was like what really excited me, and so I've had these parallel career trajectories where I'm a practicing surgeon, urologist, but I also run a lab, and I've been running a lab since I started. And I got into this area of cancer metabolism.
Yeah, what's interesting is that, sorry to cut you off, but what's interesting is that forever, Minhaj, I was considered as a practitioner who practiced quote unquote soft medicine, diet, feel touchy stuff, feely touchy stuff. And when I see you guys now jumping on board, at least looking at it, researching it, Harvard Medical School, everything, was like, hey, what happened to soft medicine?
Yeah, you're ahead of the times. You're way ahead of the times. I mean, it's like, much respect to you and what you do, because it is such a hard topic. I mean, medicine's easy compared to what you're doing. It's like the surgery part is straightforward, right?
Exactly.
Like
it's true,
cut it
actually,
out.
to some degree or another.
Yeah, and so like what you're doing is just kind of, you go in circles. It is diet and health and cancer and metabolism are just the most complicated topics you can run. And it's just like and so so I've been studying kind of really basic cancer metabolism for years now, trying to understand how, when you're looking at a cancer cell, we talked about genomics a second ago, you can understand a cancer cell from various vantage points. Each vantage point gives you a different insight. You can start off with the DNA, the instruction. I run things on analogy. So I keep popping into analogy. These are like things I just use over and over again. And so I think of like a building. You can understand a building based on the blueprints of the building. That's the DNA. You can understand it based on the operation manual on how the maintenance person runs the building. That's the protein, the enzymes. Okay. Or you can understand it by observing how people use the building. That's the metabolism. And so how a cancer cell, the instructions within it, how it builds these enzymes that process nutrients, or how it processes nutrients to live, give you different advantage points. And so the area of metabolomics is massively growing, has a lot of promise. I got into prostate cancer metabolism because right around when I was doing my fellowship, this study came out showing that metformin, a diabetes drug, was protective against prostate cancer.
That's right.
Out of left field, not expected by anybody. And that started leading to these questions on like, how is that possible? Why is that the case? And it started getting into like, all of a sudden you started seeing that what metformin does is it does alter the metabolism. Prostate cancer is one of the unique metabolic cancers in that it's not a Warburg cancer. It is primarily fat metabolism dependent rather than sugar dependent. But these things are so interwoven that you can't just like then decide to like eat one thing, more of one thing and not of another, and expect it to kind of work out. So, but we are doing a lot of research. What I'm doing a lot of research on right now is, I mean, I have some great collaborators here. Christy Adamo, who
Mm-hmm.
I know you know as well. And I also, like, within our radiology facilities here, we have these like really fancy MRIs that can
Mm-hmm.
image metabolism in real time. So we're actually trying to use
Mm-hmm.
that information to characterize cancer cells, and then when you treat the cells, um, you can actually see the cells that are being affected by treatments in real time. This is in mice. We're not at humans yet, but like in mice, you know, where when you treat cancer, for more advanced cancers typically, but it can apply almost anywhere. You have to wait. You give a treatment, you start a drug, you wait 3 months, you see if the cancer shrunk. That's the current state of the
Hello.
field.
I
But the
think you
hope is that
froze.
actually you can actually start to see the metabolism change within a day or two and get quicker feedback. So that's some of the stuff that we're working on. So the analogy I use is that, like, if you're looking,
Mm-hmm.
that if you have a house, right, or a building, you can understanding cancer from different vantage points, whether it's metabolomics,
Right.
genomics, proteomics.
Right.
These are the different labels we use.
From any omic.
If with
Yeah. Yeah.
the omics,
Yeah.
multi-omics is a thing that you combine one or two of the other omics and you get multi-omics. And so, if you look at the blueprint, that's the DNA. If you look at the machines that are set up, that's the enzymes. If you look at the way that the papers flow and the people walk through the building,
Excellent.
that's the
Mm-hmm.
metabolism. Okay. And so the work that we're working on, is a lot of it is actually, the future is treatment, but currently it's just kind of
Mm-hmm.
understanding the cancer better and understanding how it's working. And so a lot of like risk stratification, differentiating more aggressive ones from less aggressive cancers. We have great collaborators here.
Mm-hmm.
I know you
Mm-hmm.
know Christy Adamo, and also he does like integrative health. And then like we have like I have this access to this like specialty imaging here that does, it's
Oh.
called hyperpolarized imaging. It lets you image
Mm-hmm. Oh,
metabolism in
wow.
real time using MRI. And so you can see the areas of the prostate that have
Mm-hmm.
increased metabolism and what type of metabolism it is. And so that's really exciting because, right now when you start someone on cancer treatment, this is typically for more advanced cancers actually, but can apply everywhere. You have to wait like 3 months
That's right.
to see if the
Mm-hmm.
cancer
Mm-hmm.
shrinks. But if you can see the metabolism, you can do a before and after within a
Wow.
day or two of trying the drug, and you can see if the metabolism is if like the cancer cell is not doing well, essentially. And it may take a while for it to shrink, but you can tell that it's not doing well right away. And so that's some of the
That's
exciting stuff that's
fascinating.
kind of out there. We've played around with some of the stuff you do with like trying to use diet to
It
intervene
is
on
hard.
cancer. It's
It is
very
hard.
hard,
And like diet and
very hard.
exercise, for example. So, what study was
Yeah.
it? They said, well, diet decreased the risk of advanced prostate cancer by 25%. I'm butchering the numbers here a little bit. But when they did aggressive or moderate to high intensity exercise, it increased it by, or decreased the risk by 40%. I'm butchering the numbers, but the point I want to make is exercise with diet was more effective than diet alone.
Yeah, I couldn't agree more. And this is, I mean, the thing is that like it's a super hard area to research, but it's so important. And I think sometimes like just because it's so hard to research and because so many studies have failed, like the research community has a hard time putting
Yeah.
their kind of brains around it. But so I had,
Mm.
tying together how we first met,
Mm.
the way I met Howard Walensky was through this thing that has become an initiative called the Prostate
That's
Cancer
right.
Active Surveillance Research Initiative. And it's this project that started almost 3 years ago now, where we brought together
Mm-hmm.
patients and physicians to do joint collaborative decision making on
Mm-hmm.
prioritizing prostate cancer research. And actually we held like a 2-day conference together, which was attended by like about 100 patients and 50 clinicians. Howard was one of the people that was involved with all this. And we came up with the top 8 through this joint iterative process. We came up with the top 8 priorities for future active surveillance research. And sprinkled within that, the reason I'm bringing that up now is that sprinkled within that diet and exercise were
Beautiful.
like right in there, and the number one priority that came up through this joint kind of process was actually how to use MRI intelligently for augmenting active surveillance. And so, all the stuff we're talking about is
They
like
want to
what
know
people want to
about, they
know
could be
about,
more
what
proactive.
patients.
And, I had Phil, Dr. Phil Pizzarno, another, I'm butchering his name a little bit.
Yeah,
Yeah, Parazio.
Parazio. Yeah,
Who, I had him
yeah,
on as well. By the way, there again, I was at Columbia doing the research with Aaron Katz, early 2000s. Parazio was a medical student. And there again, it was a scenario we were talking about it. I'll let you know when it's published, because I think you'll find it interesting. Here I am doing this research on, again, it was considered soft medicine, and I'm like, I'm in the closet, literally, like, I don't even want to let people. This is my passion. This is what I care about. But man, no one else cares about it. If you're not a surgeon, then who are you? That's kind of how it felt like. Yeah, even back then there
yeah,
was no HIFU or focal ablation. It's either surgery or radiation. Period. End of story. And that's hardcore medicine that takes care of the cancer. Anyway, I'm in this little corner doing this research on these nutrients and things like that. Parazio was medical student, and we were talking about that because now he has this like Zen operating Zen podcast. I was like, what?
yeah,
What?
yeah.
So we were talking about that. I was like, I can't. I am still in awe when I go to the AUA. People pull me to the side all the time. Says, okay, what's a protocol? What's a nutritional protocol? All the time. So it's really is mind-boggling. It's fascinating, and I talk about it all the time with anyone. Like my wife knows about it. She's like, "Remember those days that I was like, I'm pulling my hair." Not that I had much back then either. And here we are, all these years later. This level of interest is unbelievable. Um, so ketogenic diet. So we know that prostate cancer is more of a lipophilic type of cancer, or likes more lipids or fats for its growth. But there's a difference between low risk, intermediate risk, high
Mhm.
risk prostate cancer, and then once there's metastasis. Where do we know that is lipophilic versus or glycolytic? What stage? Once they have
Yeah,
bone mets or soft tissue mets?
yeah. I think metastatic lethal prostate cancer, you start to see secondary changes that it starts
Mm-hmm.
to become a Warburg cancer. And at that point, like these types of things, like the so F,
Mm-hmm.
there's a type of PET scan. We use in
Mm-hmm.
prostate cancer, we use a PSMA
Mm-hmm.
PET. PSMA is a like a
Mm-hmm.
membrane marker that can be detected. The PET scan that you hear about
Mm-hmm.
with other cancers is called FDG PET. FDG is a
Mm-hmm.
type of, looks like sugar. And so most cancers light up on FDG PET, but prostate cancer early stage does not. Late stage, it's variable, but
Even
it
in
more
late
of them
stage is
do. And
variable.
so that
Okay. So
it's
that's
variable.
there would
Yeah,
indicate
yeah,
that there's it's not a Warburg type of cancer.
yeah. It's not a traditional Warburg exactly. I think the more consistent changes are
Hmm.
the fat metabolism changes
So I don't know.
in
Mhm.
prostate
I'm
cancer,
sorry.
but it's tricky. Yeah, go ahead.
I don't know what that means dietarily necessarily. Here's why. There's a
Yeah,
lot of different types of fats, right? And when then each category is
yeah,
saturated, unsaturated, there's like three other categories: polyunsaturated, omega 3, omega 6, omega 9, things like that, right? You need fat, like you need
yeah.
protein, like you need carbs to sustain yourself. So are we just choosing, is it a trade-off? Like I'll be less healthy perhaps, but not feed the cancer? Or some of these cells make their own fats to feed, to feed themselves. So some of it is created by the cells themselves, not necessarily dietarily. So I've put people on ketogenic diet with prostate cancer initially more from a metabolic perspective, because they have metabolic syndrome, and I find that, right. So from that perspective, I put
Yeah.
people on keto. But if they're not obese or have metabolic syndrome, I don't put them. I put them on a sort of a plant-based diet that modified with fish and things like that. So what
Yeah.
have you found? I know in our past talk you said, look, I tried the ketogenic diet. That thing is hard. So that's the other element. It could be the best diet in
Yeah.
the world, But if the person is not following it's not going to work.
Yeah, I think I agree with all the above. So here's my thoughts is that, I mean, diet, these things are so hard. The effects of changing diet are so hard to predict, as you know. I mean, who would have thought that eating more fat will help you lose fat,
With the
right? And
exception
so,
of
like,
Atkins,
if
maybe.
that's where we're starting, yeah, yeah. And so, like, um, I think that there are like body fat content in the body um, does support prostate cancer. That seems to
Mm-hmm.
be a little more solid. And if you can cut down on body fat for people who have excess body fat, you are probably like the fat makes hormones that support prostate cancer, and that's the primary driver of
Mm-hmm.
prostate cancer growth is this hormonal pathway. And so, if you can cut down on excess body fat, whatever works for you, you're probably doing yourself a service in any number of ways, but also from a cancer perspective. And so, from that perspective,
Yeah.
keto can be very effective for some people, and I think it's great.
Mm-hmm.
Inflammation pathways are very important for prostate cancer, and similarly, I think my understanding is that like keto can be beneficial,
Right.
especially if you do like the right type of keto for inflammation globally. So the types of things you can do, antioxidant based and like nutrition based, that improve your and exercise. I mean, the exercise actually helps a lot on that side too, I think. And so, if you can improve your body's general state of being in terms of
Yep.
inflammation state, that is also very helpful for prostate cancer. And so, I think that like what you eat directly going into cancer is
Right.
not super easy to control. How you are as a person globally in terms of health and how that affects the cancer is
Yeah.
probably more effective. And so I think if you use your nutrition to focus on your body's health rather than the cancer and then use your body to fight the cancer, you're better off with that two-stage thought process
Yeah.
than trying to think like how, is this cheeseburger
That's a
good
great
for my
point.
cancer or bad for my
I always think
cancer?
of it. You want to treat. So people ask me all the time, how do you treat prostate cancer with natural and lifestyle interventions? My response is, I don't know that I'm treating cancer with lifestyle interventions. What I am treating is your microenvironment. I want to make your microenvironment
Yeah.
hostile to cancer cells because what the damage occurs when it starts moving around. If it stays put, depending on where it is, but if it stays put, you're fine. If it starts moving around, that's a problem. So I'm treating a microenvironment, which I think is really important. So within that comes all these what I call microenvironment biomarkers. So I do look at C-reactive protein and hemoglobin A1C and all these things that most urologists don't look at because that's part of the microenvironment.
Yeah. I think it's great. I think that's exactly the right way to kind of frame it. And I think that probably is I think as a field, that is probably the direction that we need to kind of hone in on. I think that a lot of the work that has been done to try to look at how these
Missing the boat.
interventions affect cancer you know have yeah,
Missing the
they've all
boat.
been null
I think
results,
it's
like
missing the boat. You know,
not
and
yeah,
this doesn't mean that a
yeah,
patient doesn't need treatment, right? So they could have prostatectomy. What's the recurrence rate after prostatectomy or radiation? I don't know, 40% within 10 years or so. So let's treat the microenvironment. They're
yeah,
even more so in that scenario, right? I
yeah,
think that will reduce the recurrence rate.
yeah.
Min-
Yeah, because everyone's different, and like what the thing is, it's not like a drug
Mhm.
targeted to a specific pathway where you can
It's
kind
just
of
a whole
use it on
different
all the same people, right?
philosophy
Like,
of how you're looking at it.
yeah, like an obese person versus like a
Yeah.
really malnourished thin person
Correct.
has
And
totally different
obviously, so there's
needs.
this thing called thin fat where people are thin but very high body fat. So those people concern me too. This is why you can't just
Yeah,
look at BMI. I think BMI is not a great thing. Clearly, obese is obese, but in a certain group of people where they're not obese, they're overweight, or they might be overweight, or they might not be overweight. Um, they may have low body fat and look big, or have high body fat and look slim or thin fat or slim fat. So those are all areas
yeah,
that are fascinating.
yeah. That's and exactly. And I think once you start thinking about that, and then it's just a lot easier to grasp. And I bet you that this is the type of stuff that's going to really pan out. I mean, that's it's great that you kind of have it framed that
Yeah.
way because I
All
think that
right,
it's really
Minhaj.
helpful.
Here, last question. 2014. 2014. You are the
Mm-hmm.
primary author
I know it's coming.
of this paper
Yeah.
suggesting correlation, not causation, that vasectomies increase the possibility of advanced prostate cancer. This is a Journal of Clinical Oncology, I want to say.
Yep.
You have no idea what you've cost with that paper, and how many times I have to answer questions with regards to
Yeah.
vasectomies and prostate cancer. I mean,
Yeah.
that's probably the most famous. You become famous from that paper more than any others, I would assume, because it keeps coming up.
Oh my gosh. It's that was a crazy paper. So this is how this paper started. You know, some 20 years prior to that. So this is when I was actually still a resident at MGH and in the Harvard system, and I was just I was kind of exploring different research areas, and I collaborated um, with
Mm-hmm.
Dr. Lorelei Mucci and Ed Giovanici, and at the Harvard School of Public Health, and they oversee this. I mean, they're part of this big group that
Mm-hmm.
oversees the health professional follow-up study, which is this 50,000 patient or person cohort of people who've been followed for years,
Yeah,
and
for
lots
sure.
of amazing stuff has come from that study. And they
Mm-hmm.
published in like the early 90s, I believe now, that they found in this cohort, and it has just lots of details, that study, and they published in the 90s that they had information on vasectomy and they had information on prostate cancer, and they were observing that
Mm-hmm.
people who had vasectomy had more prostate cancer. Now, that initial study was
Mm-hmm.
criticized very strongly, because and many criticisms were correct, because there's thought confounders. People who get vasectomies are different than people who don't get vasectomies. They might have more involvement with urology, more access to urologists, just as a screening step, and so you have biases built in that can account for why all prostate cancer is detected in one population more than another. And so, but it's an open-ended question. It's an interesting question. And so we figured, why don't we
Sure.
study lethal prostate cancer? Because, asymptomatic, clinically insignificant prostate
Yeah.
cancer, if you don't look for it, you
Yeah.
won't find
Exactly.
it, and you never would have known you had it. Lethal
Mm-hmm.
prostate cancer, it's hard to like miss it. Like if it's killing you, no matter where you live, no matter what kind
Yep.
of access to healthcare you have, you're probably going to find it. The assumption, the hypothesis, was that lethal prostate cancer would not show a association. So we do this study, and lo and behold, we're observing in this cohort that there is an association. And so, I'm a urologist in training at this time, and what's going through my mind is, if I publish this, my field will disown me right at the beginning of my own career. Uh, and so it was like this very tricky thing, but I had a lot of good mentorship, and I learned a lot. I learned that when you do research, you try to do as good a job as you can,
Mm-hmm.
and you publish what you find. And so that's ultimately that's what we did. Now, I think it's extremely important. So the risk noted was small. 10% increase in risk. This is called a
Mm-hmm.
relative
Mm-hmm.
risk. We start getting to like wonky statistics here a little bit. What's really important to know is the absolute risk. That is the risk that when a patient who is deciding to do, the question that a person wants to know when they're making a decision on something is, if I do
Mm-hmm.
this, how much more risk am I at? That's an absolute risk. That's actually not a relative risk. So, they want to know the answer to, okay, if I get a vasectomy, what are my chances, increased chances of dying of prostate cancer if this data turns out to be true? Okay. And that number is 1.2%. Okay. And I think when you give that context, it should not be the driving reason one chooses to or does not choose to get vasectomy. On top of that, other studies that have been also really well done with large cohorts that were followed over a long period of time have failed to show this
Was it a,
association.
a, a good
You
a
know,
good of a
it
study
isn't
as
like you.
yours? Was it? Did they look at all the key factors. Yeah.
I would say, yeah, I would say some of them are. I'd say that there's like a handful of them, like 2 or 3 studies out there that are just as good that fail to show an association. So the data are conflicting. It's a almost impossible question to study the mechanism of, because the difference in time between the event of vasectomy and the
Mm-hmm.
event of prostate cancer is 20 years. And so it's really hard to
Mm.
like understand, a
Yeah.
lot happens in 20 years, no matter who you are. And it's very hard to kind of link those two together. So
Mm.
in my mind, this is an open-ended question. um, I think that it may be interesting from a scientific
Mm.
perspective on better understanding what causes prostate cancer. I don't think it should drive policy.
What's
I
the
don't even think
mechanism?
it should really
Why
be
would it
driving
be?
much in terms of
I had
decision
because I
making.
that I cannot figure out.
That's Yeah, I mean and that's the thing. I mean, that's where I get stuck too. Like that there's been some like really rudimentary studies. There are certain signaling proteins coming from the
Mm-hmm.
testes that don't make it up to the prostate anymore once you do a vasectomy. Whether that kind of signaling protein not making it, like they're contained in the fluid that is coming from the testes itself, because you're cutting off the tubing that transports the fluid from the testes, or plus the testes are a source of all kinds of hormones. I mean, testosterone being the main one. And when you do a vasectomy, is there a change in that? But I mean, most studies have not shown much of a change. So it is unclear what the mechanism of. There's definitely not a clear, straightforward mechanism. And so that's why when I put it together, I mean, I counsel patients.
So this is what I do when they come to me, whether or not they should do a vasectomy. I discourage them if they have, not if their father or uncle or brother had prostate cancer, but if they died from it, or if they were diagnosed at a very young age with moderate, intermediate to high risk disease. This is all my clinical opinion. Or if they have a BRCA2, BRCA1 mutation, which I would test for germline mutations. Um, More or less that's pretty much it. I would discourage it. And I would say, look, I really don't know. So, but you're at higher risk. The study showed what it showed. Maybe I want to decrease the likelihood of you being part of that 1 point something percent. So maybe that's not a good idea for you.
Yeah. And that's really the key. I think that for someone who is terrified of this, who's lived this experience where their parent died at a young age, or their brother or their grandparent or something, and this is a driving thing that and you tell them that this, if everything really kind of plays out, it may increase your risk by about 1%, and they
Mm,
hear that number and they
mm,
say vasectomy is not worth it. Well, then there you go. I think that is an informed decision making. And similarly, you hear someone who's like, well, there's a
mm.
lot of benefits that vasectomy can have on my life right now,
Yeah, right,
right?
exactly.
Like I just don't want another kid, like right? And like that's a big deal to them. And they hear this and they're worried about prostate cancer, but you tell them that, look, it looks like it's about a 1% increase absolute risk of having prostate cancer. Then 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 they should get it, and they understand the risk.
Yeah, right, exactly. That's awesome. Dr. Minhaj Siddiqui, thank you so much, sir, University of Maryland. How can people be in touch with you if they want to connect?
The easiest way is they can look me up on the if you look up Minhaj Siddiqui, Minhaj Siddiqui, Siddiqui, University of Maryland, you'll find lots of contact information. My office number for like clinical inquiries is 410-328-6422.
We'll have it on our show notes as well. Thanks so much, brother. I appreciate you. I appreciate your time and your expertise in this area. I look forward to collaborations with you and your group. And keep me posted with anything you do and any information that I can spread to my audience, because I think you're doing, like many patients would say to us, you're doing God's work. So thank you for doing it.
I'd say the same of you. Thank you for having me.
I appreciate it, brother. Be well. Talk to you soon. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.